Hello, good evening, everyone. My name is Dr. Wisdom. You are welcome to another session of today's episode. So, we are running a series currently, and we are just beginning the series. This is and is titled Neuro Ophthalmic Perspective of Optic Nerve Head Evaluation in Glaucoma Management. So, is it will be a long series, and also we'll be highlighting important things to note, and we hope that this series will equip us to become better doctors, and to be able to gain mastery in the clinic. So I'm going to be looking at important landmarks. So just quickly on our table of contents, there's an introduction, pre-assessment, what are those important things we are to look at, and then hindrances to examination, the normal optic nerve head landmarks, and physiological cupping, glaucoma damages subtypes. We're also going to look at glaucomatous cupping, non-specific signs, peripapillary atrophy, retinal nerve fiber layer, optic nerve head key parameters in OCT, and then finally we'll look at guided progression analysis, which is a recent upgrade in glaucoma management. So having said this, let us begin effectively. So let us look at the introduction. The optic nerve head, which is the second cranial nerve, is responsible for sending visual information from the retina to the brain for interpretation. You understand? So we have 12 cranial nerves, and the optic nerve head is the nerve responsible for vision. So, and also the optic nerve head is the intraocular portion of the optic nerve head. We have other portions such as the intraorbital, the intracanalicular, and so on and so forth. So, but we are, for the sake of this study, we are looking at the intraocular portion, which is the optic nerve head. Now, the retinal ganglion cells, or the axons, they converge and exit the eye to form the optic nerve. And also, the optic nerve head is anatomically composed of the neuroretinal rim, the central cup, and the lamina cribosa. We are going to be looking at all these in the course of this study, and know how to assess them effectively. Also, there are changes that are usually noticed in the optic nerve head and the nerve fiber layer before they are seen in the visual field. This is why OCT is very, very important. There are subtle changes you will see which you might not really be able to catch up, but then when we do our OCT, we can see these things effectively, and then know the appropriate treatment to go on with. So these changes most times are subtle yet quite significant, causing a lot of irreversible damage before they are actually taken seriously in the clinic. So this is why OCT remains the gold standard in glaucoma management, because there are a lot of issues, there are a lot of changes that go on that ophthalmoscopically we might not be able to get a detailed overview on. But when we send for OCT, we can see them well. But by the way, we still need to do our ophthalmoscopy, and then there are some changes we need to also note. So glaucoma is a common culprit, usually apprehended after a thorough inquiry on optic nerve head changes. So most times, because of the race, we are Africans, and our locality, glaucoma is a major, or one of the common culprits every time we are assessing the optic nerve head for changes. But that does not mean that glaucoma is the only pathology that causes optic nerve head changes. A little percentage of cupping has also resulted from arthritic ischemic optic neuropathy. Now, glaucoma is defined as a heterogeneous group of disorders which manifest as a chronic progressive optic neuropathy characterized by specific morphological changes at the optic nerve head and retinal nerve fiber layer with resultant loss of retinal ganglion cells, which result in loss of visual field. So this definition is comprehensive and all-encompassing. So it tells you that glaucoma is a group of disorders. You understand? It's a group of disorders, and then it begins to tell you that there are morphological changes we note once there is glaucoma, and then these changes are seen in the optic nerve head, they are seen in the retinal nerve fiber layer, and they are seen in the retinal ganglion cells. So these three, also in the macula as well, but these three major areas are worthy of note, and then we need to be able to assess them and know the extent to which the damage has occurred. The next point is that elevated intraocular pressure is not a diagnostic criteria for a risk factor, but a risk factor for glaucoma. So every time, most times in the clinic, once we see an intraocular pressure that is higher than normal, we just assume it is glaucoma. No, even though there's a thing called ocular hypertension, in the sense that the pressure can be high, yet everything is fine. So in that case, we call it ocular hypertension. But like the slide is saying, an elevated intraocular pressure is not a diagnostic criteria, but a risk factor. In other words, once there is elevated intraocular pressure for long, you tend to have glaucoma. But recent studies are even showing now that it is not just all about intraocular pressure, that the systemic blood pressure can also have a role to play in glaucoma, because some authors say glaucoma is an ischemic disease, and if you understand optic perfusion pressure, you begin to see the link between systemic pressure and glaucoma. But that is a topic for another day. Let's focus on what we have here today. So the optic nerve head cupping is seen in all forms of glaucoma. So every time we look at whether it is normal tension, whatever it is dramatic, whatever glaucoma we are looking at, there will always be a form of cupping, which is important to note. Other forms of attack on the optic nerve head result in glaucoma cell damage and pallor. Only glaucoma leads to cupping. Only glaucoma leads to this cupping we are looking at. So there are some pre-assessments we need to look at in order to, before we begin the optic nerve head assessment effectively. So case history, like in all optometric examination, case history is important. It is important that we do a thorough case history to know what the issue is, and the next is visual acuity. And meanwhile, in your case history, it is important to note if there's a family history of glaucoma. All these three, they help in our diagnosis. And also the visual acuity is important because glaucoma is a progressive condition. It is important that we note the visual acuity on every visit, so that if the patient came 2 months ago and is having a visual acuity, or he had a visual acuity of probably 6.6, and then 2 months after then he's coming to the clinic and we see a vision of 6.12, 6.18, it tells us that something is wrong in our management. It's either we change our management plan or we re-evaluate whatever we are doing. So the visual acuity is very, very important and paramount every time we want to assess a patient who we are suspecting or who has already been diagnosed of glaucoma. Also want to look at the pupils, make sure that the pupils are reacting. You know, in some forms of glaucoma, the pupil can be dilated, so we want to be sure that the pupil is not dilated. Also, color vision assessment is very important. Slit lamp examination, tonometry to check the eye pressure, and then finally gonioscopy. So let's look at the hindrances to optic nerve head evaluation. The first is a myotic pupil. So now during ophthalmoscopy, it might be difficult to see the optic nerve head properly with a patient who has a myotic or a constricted pupil. So we see miosis majorly in elderly patients, or it can also be drug induced. Well, either ways, a small pupil might reduce your vision to see the optic nerve head effectively. So this is one of the common challenges we might be able to face in the clinic. Now, how do we overcome it? We can dilate the eyes if after checking the eye pressure and then assessing the anterior chamber that it is fine and the pressure is normal, it is safe to dilate. Also, you may want to go to a dark room and then perform ophthalmoscopy there, so that because in a dark room the pupil will surely dilate, and then you are able to see the optic nerve head effectively. Also, another hindrance is optic nerve head drusen. So when there's a drusen, you might find difficult trying to understand or seal the boundaries of the optic nerve head. So this is where superior tests like your OCT, your fundus camera, all that come into play and helps you to identify what you want to identify. The next, the tilted optic nerve head. We will look at tilted optic nerve head in details after now. And again, a photophobic or uncooperative patient. So when a patient is photophobic, they tend to not cooperate. Or there are patients who they are not photophobic, but generally they are not cooperative during ophthalmoscopy or even during an OCT examination. So these are common hindrances you might face. But then every hindrance has a solution. So it's just left for the practitioner to find a way to maneuver through it. So just in case you are joining or you've joined from the earlier, please make sure you subscribe, like, and comment on this video, and share it to colleagues. I'm sure it's going to help you in one way or the other. So let us look at the normal optic nerve head landmarks, which is the neuroretinal rim, the optic disc, and the inter-eye disc in asymmetry. So these are the three things to be looking at. So let's look at the neuroretinal rim. The neuroretinal rim is the orange pink tissue between the disc margin and the outer edge of the cup. So it is pink in color. It is important that we note the color, that it is pink in color. It is a tissue that is pink in color between the disc margin and the outer edge of the cup. So every time we see a change in color, we want to question why. So but the normal color is pink, and then it is the convergence of the retinal nerve fibers as they enter the optic nerve. So it is part of the optic nerve, the neuroretinal rim, and a large disc should have a corresponding large rim. So whenever you see a large disc, it is important to note that you will also see a large rim. So if you are seeing a large disc and a small rim, you need to question why it is so. And then the broadest is the inferior rim, followed by the superior, the nasal, and the temporal, commonly known as the Ising rule. So the Ising rule states that the inferior neuroretinal rim should be broader than the superior, and then the superior neuroretinal rim should be broader than the nasal, and then the nasal should be broader than the temporal. But then glaucoma doesn't obey this rule, resulting to thinning of the rim. So every time we see a thinning that doesn't obey this Ising rule, we know it is glaucoma. But then there are, like I said earlier, there are other forms of neuropathies that also affect the optic nerve head. For instance, if you are seeing a result whereby the thinning begins for the temporal rim or the nasal rim, you know likely you are not dealing with glaucoma, because glaucoma will always respect this or will not follow this Ising rule. So a thinning that begins from the temporal first, while the inferior and the superior are normal, we know it is likely not a glaucomatous case. So this is the image of a healthy neuroretinal rim. So you can see this is the inferior rim, this is the temporal, the superior, and then the nasal. So this is what and you can also appreciate the coloring. This is what a healthy neuroretinal rim looks like. Also, let's look at the cup to disc ratio. So the cup to disc ratio, by the way, if you have any question or any comment, please feel free to drop it in the comment box. I will attend to them after this class. So the cup to disc ratio, this is the comparison between the diameter of the cup to the entire disc diameter. So the vertical rather than the horizontal is considered the yardstick. So when we want to measure the cup to disc ratio, we do not look at the horizontal part, we look at the vertical. We are not, even though in your OCT it will still tell you the horizontal cup to disc ratio, but our yardstick is the vertical portion, not the horizontal. And imaging gives the exact ratio. Aside that, ophthalmoscopy is an estimation. So in ophthalmoscopy, what we do is estimate, but your OCT gives you the exact ratio. But then it doesn't mean that the ophthalmoscope is our ophthalmoscope estimate is wrong. No, but if you are good at it, you will find out that most times you are always close to what the OCT is giving you. So I don't think you should be more than 0.2 difference than whatever the OCT is giving. If it's more than that, that means your grading is strong. But like I said, it is an estimation, while the imaging gives us the exact ratio. And the normal CD ratio is 0.1 to 0.4. So this is the normal. But some authorities will tell you even for blacks, 0.5 can still be normal. But I feel that anything from 0.5, we should begin to suspect. So when we see a cupping of 0.5, 0.6, 0.7, we do not just say it is glaucoma. We say it is a suspect, because in the course of this slide, we'll find out that there's a phenomenon called physiological cupping, which a cup can be large and yet it is not glaucoma. So the CD ratio of 0.5 and above is suspicious, yet not a final diagnosis for glaucoma, but a vital indicator that should instigate further problems. So I've said it before. So every time we see a large cup, we do not just diagnose it as glaucoma. We want to probe, why is this cup large? It could be physiological or something could be going on there, but we cannot tell until we send for a result. Medical practice is evidence-based, so we do not just assume that, oh, a large cup is tantamount to glaucoma. No, we want to question why it is so. And then 5% of normal eyes have a CD ratio larger than 0.6. Yes, it is true. 5% of normal eyes have this large cup to disc ratio, and a large cupping with healthy retinal nerve fiber is indicative of physiological cupping. So a cup can be large. Probably during your ophthalmoscopy, you find out that the cupping is large, but when you assess the retinal nerve fiber layer, you find out that it is still healthy. It is not glaucoma. It is a physiological cupping, because like we said earlier in our definition, before you will see that increase in cupping, it first of all affects the retinal nerve fiber layer and also the ganglion cell layer, because the ganglion cell layer, the ganglion cell, they come together to form the retinal nerve fiber layer, and we say that the neuroretinal rim is an extension of the retinal nerve fiber layer. So every time we see a large cup, but when we send for OCT, we are seeing that the retinal nerve fiber layer is still healthy, it is likely not glaucoma, because if it is glaucoma, there should be a corresponding loss in the retinal nerve fiber layer. There should be a corresponding loss there. So it is important that we know this. And an asymmetry of 0.2 or more between the eyes is also suspicious. So for instance, the right eye is a cupping of 0.6, or so let me say 0.4 for instance, and then the left eye is 0.8. So that 0.4 difference is suspicious. So it is important that most times in physiological cupping, you find out that even though the cup is large, but they are symmetric. So you are getting 0.8 on the right eye, 0.8 on the left eye. Yet every other thing is fine. But a difference in 0.2 or more should be suspicious, and then we need to query such. A large disc, we usually have a large cup and may be healthy. Likewise, a small disc. So it is a normal phenomenon. When you see a large disc, you expect a large cup, and when you see a small disc, you expect a small cup. Now, one of the commonest mistakes we make in the clinic is that because a disc is large, and then because the disc is large, we will also see a large cup. And because we are seeing a large cup, we just assume that, oh, the cup is large, it is glaucoma. No, a cup can be large, yet it is not glaucoma, because a large cupping will be associated with a large disc. Now, this does not mean that every time there's a large cup and a large disc that it is not glaucoma. What I'm trying to say that we do not just assume by mere inspection. We want to probe further for all other things I'll be discussing in this series. So a large disc will usually have a large cup and may be healthy. Likewise, a small disc. So a small disc with a small cup can still be glaucomatous, even though the cupping is small. So African Americans have a larger disc than Caucasian Americans. So in Africa, we are likely to see more of glaucomatous cases because we are susceptible to having a larger disc. Now let's look at physiological cupping proper. So like I said earlier, physiological cupping is a cupping that on initial inspection might want to look glaucomatous, but it's not. So this refers to a large cup appearing as a glaucomatous cup on initial inspection. So like I said, not every large cup is glaucomatous. So but when you inspect, you'll see that it is large. You want to probe further. So the normal in a physiological cup, you will, apart from having a large cup, you will note the following, that the retinal nerve fiber layer thickness is normal. So when you send for OCT, you will find out that the retinal nerve fiber layer is still normal. So this is one point to note. You will also note a healthy neuroretinal rim. Like I don't know if I've said it, but let me say it now, that a loss in neuroretinal rim is more indicative of glaucoma than a large cup. So every time we see loss in neuroretinal rim, it rings more bell than a large cup, because a cup can be large and it's not glaucoma, but a loss in neuroretinal rim is definitely something is wrong there. So apart from the normal healthy retinal nerve fibers you will see, you will also notice a healthy neuroretinal rim. And also when you do your CVF, you will see normal visual fields in most physiological cup. And also when you inspect the ganglion cell complex, it appears normal. So with all this, when we have all this in place, we can confidently say that, oh, this cup is a physiological cup and not a glaucomatous cup. Also, it's usually similar in both eyes, but not in all cases. So you find out that a physiological cup, you will be seeing the same 0.7, for instance, on both eyes, whether it's 0.8, usually the same on both eyes, but not in all cases, like I said earlier. So this is an image of a physiological cup. This is an OCT result. You see a physiological cup with healthy retinal nerve fiber layer. So when we look at the retinal nerve fiber layer thickness map, we see that the layers are healthy. We see that the retinal nerve fiber layer is healthy. When we look at the parameters, which I'll be talking about later, you find out that they are all within normal range, even though the vertical cup to disc ratio is 0.6 on the right eye, 6.4 on the right eye, and 0.6 on the left eye. Now, if you had done ophthalmoscopy, you would have seen that, oh, the cup is abnormal. But then we are seeing that on our OCT result, you find out that every other thing is normal. If you look at your retinal nerve fiber thickness map, you find out that comparing this patient to his age group, everything is fine. You also look at the neuroretinal rim thickness, it is fine. You look at the retinal nerve fiber layer thickness, it is fine. Even look at the quadrants, the RNFL quadrant, everything is fine. So in this case, it is just a large cup, but not a glaucomatous cup. Here is another image of a large physiological cup. These photos of the right and left, it shows rounded symmetrical cupping with healthy neuroretinal rim, and C shows OCT of the right and left eye of the same patient, which shows a normal nerve fiber thickness. The patient also has normal IOP and visual field. So if you look at this patient, now this is the ophthalmoscopic result or the fundus camera. You look at this, it appears glaucomatous. You question, you understand, you see that this is a large cup. I might want to grade this probably 0.8 or 0.7 for A, and B 0.7 as well for B, 0.82 within that grade. But then when you look at the the OCT result, you find out that the RNFL thickness map is within the normal limit. Look at the color grading here. You find out that they are all within normal limits. So even though the IOP is normal, visual field is normal, everything is normal, but we are just saying a large cup. So in this case, it is best to say, okay, this is a glaucoma patient, let us keep in view, than to just diagnose glaucoma. Are we together? It is best that, okay, this is a glaucomatous patient, let us keep in view, and then see, maybe repeat this test in 6 months time, repeat this test in 3 months time, or 6 months is better, or 1 year time, and then we compare what we are seeing now with what we have in 6 months time. So this is a better approach than to just diagnose, because our result is showing us that this is a physiological cup and not a glaucomatous cup. Now, this is a finding in a 26-year-old woman with multiple sclerosis related optic neuritis with subtle temporal thinning in the left eye. Now, this here is the first result, and this here is the result after some months. Excuse me. Now, if you look at this result, you find out that even though the retinal nerve fiber layers appear healthy, but if you look at this point, you will see a temporal thinning. Remember we said earlier that glaucoma doesn't obey the isn't rule. Now, every time you are looking at the result and you are seeing a thinning at the temporal portion first, before the inferior, the superior, we know we are not dealing with glaucoma. We know we are not dealing with glaucoma because if it is glaucoma, it's going to affect the inferior and the superior portions first before the temporal and the nasal portions. So, but in this case, we see that there's a subtle temporal thinning in this patient eye. You see somewhere here, and again, you also see this arrow here showing you the temporal thinning here. So you find out that this is not a glaucomatous case, but then a case of a 26-year-old woman with a multiple sclerosis. And again, multiple sclerosis can which cause an optic neuropathy, and optic neuropathy will also affect the optic nerve head. So it's important that we differentiate these two things and do not call every form of cupping a glaucomatous cupping. Now, having said this is an image of different types of cupping. So we see the normal optic nerve. This is a normal cupping. Here we see a mild cupping, and here we see severe cupping. So there are important things we need to note here, but I don't want to be faster than myself. So these are different types of cupping: normal, mild, severe, according to how you want to categorize it. So let us look at glaucoma damage subtypes. Glaucoma damage subtypes. So there are four types of glaucomatous damage. We have the type 1, type 2, type 3, and type 4. So let us look at the type 1 quickly. So the type 1 is also called the focal ischemic disc. Type 2 is called myopic disc. Type 3 is called sclerotic disc, and type 4 is called a concentrically enlarging disc. So when we say this is a type 1 glaucomatous disc, we mean that it follows the pattern of the focal ischemic disc. Now, let's look at focal ischemic disc. In focal ischemic disc, they appear as superior and or inferior notching, while the rest of the neuroretinal ring appears healthy. So you find a superior and or it's either it is both the superior and inferior, or just one of them, it has a notch, and then other part is appears healthy. So a notch is a localized well-shaped thinning or loss of the neuroretinal ring, which usually precedes disc hemorrhage. So every time we call a thing a notch, we are saying that there is a loss in neuroretinal ring in that area. So it is localized, it's not generalized. So a focal ischemic disc notch is a localized loss in neuroretinal rim. And also a notch in the superior rim will correspond with a blind spot in the opposite side of the visual field. So what we are trying to say is that if we are seeing superior notch, there is a loss of neuroretinal rim in the superior part of the optic nerve head. When we do the CVF test, the loss, the scotoma we are going to be seeing will be in the opposite portion of whatever we saw it. So if we saw the notch superiorly, we will see a loss, a scotoma inferiorly. If we saw the notch inferiorly, we will see the scotoma superiorly. So it's always in the opposite direction. Now also a notch, okay, I've said that a notch is more predictive of glaucoma than a large cup. So a loss in neuroretinal rim is more predictive of glaucoma than a large cup. So we do not just see a large cup and then say it's glaucoma, but when we see a loss in neuroretinal rim, we are more comfortable to say, okay, this is glaucoma setting in, or this is already a glaucomatous case. So this is an image of an inferior notch. So if you look at this picture, you will find out that the neuroretinal, which is the distance between the disc margin and the cup margin, you find out that it is wide here, but when it got to inferiorly here, this inferior portion, you find out that there is a loss in the neuroretinal rim. So this loss in the neuroretinal inferiorly, we call it the inferior notch. So in this patient now, when you do a CVF, you find out that their CVF results, the scotoma will be superior because of the inferior notch here. But if the notch was superior, you will find the scotoma inferior. The next is myopic disc with glaucoma. This is type 2. So this is seen as a tilted disc or a disc obliquely inserted, appearing shallow. So in this disc, it's as if this one is inserted, not aligned very well. So it appears obliquely inserted and appearing shallow. Now the optic nerve head appears larger than normal. Also, there is posterior scleral thinning present. Temporal crescent of peripapillary atrophy is usually present in myopic disc with glaucoma, and other features of glaucoma damage are also present. It is common in younger males. So you see this kind of disc. Let me show you a picture of what I'm talking about. So you find out that this is what the myopic disc looks like with temporal crescent. So this is the temporal crescent where my cursor is. Now if you look at it, it's as if it is not properly aligned. It's as though it is tilting somewhere, tilting to a particular part. So this is what we call a myopic disc with glaucoma. So it is important that when we see this, we note this. Now this should not be mistaken for the morning glory optic disc that wants to appear. But in the morning glory, you find out that the optic nerve hairs will come here and they stop at this point. So, but this is not a morning glory this is myopic disc with temporal crescent. The next is sclerotic disc. So it is characterized by a shallow, gently sloping neuroretinal rim and sus-right cup. There is a widespread thinning of the neuroretinal rim rather than a localized notch. Remember, in focal ischemic notch, we say that the notching is localized. It could be inferior, it could be superior. But in a sclerotic disc, we find out that the loss in neuroretinal rim is generalized. So there is a thinning of the neuroretinal rim in all 4 quadrants, and it is accompanied with a surrounding atrophy of the choroid. So there's an atrophy of the choroid, and also we see it more in older patients and usually associated with systemic vascular diseases. This is why case history is very important, because in case history we tend to know what the systemic condition of the patient before we delve into the ocular condition of the patient. So this is what a sclerotic optic disc looks like. This is a classic type 3. It's a nice sclerotic optic disc. The disc has a shallow sus-rise cup with gentle sloping sides and a ring of surrounding peripapillary atrophy. You can see the ring here, and again you can see that there is a generalized thinning of the neuroretinal rim, both superiorly, inferiorly, and what have you. You find out that it's like a sauce, and then so this is just what like we said, it is seen more in elderly patients. So this is the sclerotic optic disc type 3 disc, if you may call it. And then the next is concentrically enlarging disc. So in this disc, we see that the cup appears to be enlarging with time over close monitoring. So the cup keeps getting better. But it's important to note that a rapid loss in neuroretinal rim is not glaucoma. So glaucoma is never rapid in its loss. It's a gradual progressive loss. So it's not what we see maybe 0.6 today and next month we are seeing 0.8. It is not glaucoma. So but here it appears to be enlarging with time over close monitoring. And then the neuroretinal thinning is uniform, and there's presence of a diffuse visual field loss and presence of elevated intraocular pressure in the concentrically enlarging disc. So now let's look at how do we differentiate a glaucomatous cup from a non-glaucomatous cup, because this seems to be where the issue is, that every time we are looking at a cup, we want to know how we can be able to differentiate a glaucomatous cup from a non-glaucomatous cup. For glaucoma patients, the optic nerve health changes should correspond to the visual field loss. So this is why we do not just interpret results in isolation. We want to look at the fundus camera. We want to look at this visual field. We want to look at the OCT. So when we bring all these things together, pachymetry results, all this and that. So when we bring all this together, it gives us a detailed and a better approach to diagnosis. So we want to see that if we are seeing for a optic nerve changes, it should correspond to visual field defect. But it's not always the case. There are some patients whereby you see the cupping of 0.8, 0.9, they still have 6 vision. But in most times you see that the optic nerve changes should correspond to visual field defect. So when we do, if our CVF is correct, we want to see those defects because of this large cupping, because they should marry each other. Also, a patient with superior notch of the optic nerve should have a corresponding inferior visual field defect and vice versa. So what we are trying to say that if the loss in neuroretinal rim is superiorly, when we do our CVF test, we will find out that there is an inferior visual field defect. So it's always in the opposite direction. And then a mismatch between the degree of optic disc cupping and the degree of visual field loss, or if there's a visual acuity loss of proportion to the optic disc cupping, a compressive optic neuropathy or other non-glaucomatous optic neuropathy should be suspected. What we are trying to say is that whenever there's a mismatch between the degree of optic disc cupping and the degree of visual field loss, for instance, you are seeing a visual field loss that is so much and then the cupping is not large, we want to question why. And again, remember that glaucoma respects the horizontal meridian. So when we are seeing a loss in visual acuity, for instance, and we are seeing in the visual field, we are seeing vertical loss in the visual field, we know we are not looking at glaucoma but something else. And again, a comprehensive optic neuropathy or any other thing should come to mind, but not just glaucoma. And then non-glaucomatous discs often present with manifest pallor of the neuroretinal rim. So we'll look at pallor shortly, but pallor is just the paleness of the neuroretinal rim. So non-glaucomatous discs often present with a manifest pallor. So the next thing we have to note is the visual field defect should respect the horizontal meridian in glaucoma. We said it before and it's very important. So when you do your CVF test and then you are seeing a result that is respecting the vertical meridian, we know we are not dealing with glaucoma. Glaucoma always respects the horizontal meridian. Also, a cup disc with visual field changes, visual field damage in the vertical meridian is not glaucoma. It is never glaucoma. So every time we see a cup disc with visual changes in the vertical meridian with your CVF, it is not glaucoma. It is something else, an optic neuropathy, whatever it is, but it is not glaucoma. Also, arcuate and altitudinal defects are characteristics of glaucoma. Yes, this is true. The speed of progression in cupping is usually slower in glaucoma, but fast in non-glaucomatous cupping. So this speed of progression, glaucoma is a progressive loss in vision, but when we see a quick progression, we know we are not dealing with glaucoma but a non-glaucomatous form of cupping. So it is important to know that an OCT result that shows a loss in the neuroretinal rim starting from the temporal or nasal portion is indicative that you are not dealing with glaucoma. I've said this before, but it's important that we say it again. So in glaucoma, it usually begins with the inferior and the superior before the temporal and the nasal fibers are affected. So let's look at this picture. We see a patient with a large physiological optic disc cup and intraocular pressure within the normal range for the right eye, followed for 4 years without any sign of progressive optic neuropathy. Note that all RNFL and GCC parameters are within the normal range for A, and then patient with, now for B, is a patient with glaucomatous cupping and intraocular pressure within the normal range. Note that the inferior RNFL defect associated with superior visual field loss and abnormal RNFL and GC parameters. So let us look at A. You see that even though this is A here, this is the fundus image, even though the cupping is large, but then when we look at all other parameters, they appear healthy. But if you look at this B now, and okay, look at the visual field of A, you see that the visual field is fine, nothing is going on there. But we see this case, same large cup, but then when we send for OCT, we are seeing that there is a thinning here. There's the inferior in the inferior portion, there's a loss in the RNFL defect. You understand? So which means because it is inferiorly here, in your CVF you will find these dark spots, these dark dots superiorly. So it always corresponds inferior on your ophthalmoscope or OCT. In your CVF you see it superiorly, and superiorly you will see it inferiorly. So this is just that for this patient. Now let's look at this interesting case. Now this is a comparison. This is a comparison of two cases, A and B. A is a comparison of a glaucomatous and a non-glaucomatous cupping. So in A we see a non-cupping. So if in this case you find out that this, even though this patient is having a large cup, but then you see this CVF result, it is respecting the horizontal meridians. But in B, the patient has a planion sphenoid meningioma, and then you find out that in the CVF result, you find out that it doesn't respect the horizontal meridian, but there's a loss in the vertical meridian. So this is very, very important, because upon inspection, you are likely going to just assume that there is this is a large cupping, therefore it should be glaucoma. But when you do your CVF, find out that the pattern in which it follows is a key to let you differentiate a glaucomatous cup from a non-glaucomatous cup. So having known the difference between glaucomatous and non-glaucomatous, let us look at glaucomatous cupping effectively. So in this place we have focal notch, shallow cupping, beam pot or deep cupping, and vertical cupping. These are the types of cupping we'll see in the clinic. So in the shallow cupping, usually seen in the early stage of glaucoma and occurs due to loss of nerve fiber tissues, and then there's usually no involvement of the lamina crebosa. Appearance is usually less significant in the clinic, and it's also seen in other conditions such as ischemic or comprehensive optic neuropathy. While for the beam pot cupping, we see is a specific morphological change seen in advanced glaucoma with significant vision loss of the deep cups. So it is an indicator of poor prognosis in glaucoma. So we usually see it in advanced cases of glaucoma, or the prognosis is poor. So for patient who wants to go for surgery, is an important prognosis to look out for. And again, large cupping present with a beam pot appearance. So the cup appears as if it wants to bulge out. So that's what we call a beam pot appearance. And there's also a loss of neuroretinal rim, and also posterior bowing of the lamina crebosa with these pores visible, and bayoneting is present. And then when you look at your CVF, you will see a lower mean deviation in the visual fields, and there's also thinner retinal nerve fiber layers. So this is an image of the beam pot cupping. You can note the enormous size of the optic cup together with the posterior bowing of the lamina crebosa and undermining of the neuroretinal rim. So you see the loss in neuroretinal rim here in this case, and it appears as if the cup is bulging out. And then we also have vertical cupping. So in vertical cupping, the superior and inferior poles of the optic nerve head are the most sensitive to glaucoma damage, not the temporal and the nasal. So just like we said in the in through, the inferior rim should be greater than the superior rim, and the superior rim larger than the nasal, and nasal larger than the temporal. But in glaucoma, we do not see this. So this is why we take note of vertical cupping and not a horizontal cupping. In fact, when you see horizontal cupping, most times it is not glaucoma. So a vertical cup is more of concern than a horizontal cup in glaucoma analysis. These focal changes appear and continue to occur even when IOP is under control. So this is an image of a vertical cup. You can see the loss in inferior and superior, unlike the temporal and the nasal part. So this is what a vertical cup looks like. And then we have progressive cupping. In progressive cupping, this refers to the gradual loss in the neuroretina of the discs over time. A rapid increase in cupping is never glaucoma, like we said earlier, but other neuropathies should be suspected. And we'll see progressive cupping in high myopes. There are risks of having this progressive cupping. And then comprehensive ocular examination and imaging using optical coherence tomography (OCT) is key in diagnosing this. So this is what a progressive cup looks like. So we see that in 1999 the patient was 20 years old, and this is the right eye. We see that when the patient was 20 years old, we see how what the cup was, and then when it was 8 years later, we see an increase in cup. 33 years later, we see so it keeps getting worse. When it was 34, when it was 40, this is for the right eye and for the left eye. So we see that it keeps getting, the cup keeps enlarging. So this is what we call a progressive cup. And also there's what we call a reversal of cupping. This is a rare phenomenon, but it's important that we speak about it, or I speak about it. So this is a rare phenomenon where the optic disc cup size reduces following a significant sustained decrease in intraocular pressure. So this reversal in cupping is usually by 25% or more, and is common in infants who have undergone successful glaucoma surgery. So when you see in neonates, after they have undergone surgery, you find out that there's usually this reversal in cupping, but it's less common in adults. In fact, I don't think you might see it in adults, but it's more common in infants who have undergone a successful glaucoma surgery. Also, asymmetry in cupping is important. In asymmetry in cupping, we see paired organs. So paired organs or structures are usually symmetrical. For instance, your two hands are likely of the same size and length, even though there might be some little variations, but they are usually symmetrical. Likewise, your eyes. So a difference in symmetry of the cup or more than 0.2 should be queried. So when we are seeing 0.4 and we are seeing 0.8, we want to query why is this so. So we see this case in pseudo-exfoliation syndrome, angle recession from trauma, uveitis, reversus iridosis. So these are the common causes of unilateral glaucoma, where one eye is largely cupped than the other. So this is an image of asymmetry in the cup of a patient with ocular trauma. So you see the ocular trauma was in the right eye. You see the cupping. This should be about 0.8 cupping, so large. While for the left eye, just 0.4, 0.3 cupping, and then but you see the difference. It is more than 0.2, and then this should call for questioning. Why is this so? Also, this is an OCT image of a patient with asymmetric cupping, loss in retinal nerve fiber layer, and ganglion cell in the left eye. So if we look at this patient, we find out that for the right eye, everything is fine. This is the fundus image for the right eye, and here we see that all the parameters are fine. The retinal nerve fiber layer, the parameters, everything is fine, everything is just okay. But look at the left eye. You see that in this left eye, you can see the obvious pallor here, and then if you look at there's a loss in retinal nerve fiber layer first, and there's also loss in ganglion cells. So if you look at this, the ganglion cell here, you see that there's an obvious loss compared to the right eye. So this could be likened to the image we see here, which could be this here. So you find out that there is this asymmetric cupping in just the left eye. So let's look at Pallor for today, and then so in Pallor, this is a pale or white rather than pink neuroretinal rim. So like we said earlier, the neuroretinal rim should be pinkish yellow in color, but in Pallor it appears pale or white. So this is a pale or white rather than pink neuroretinal rim, often signifying optic nerve damage or atrophy due to reduced blood supply or neuronal loss. So every time there's shortage of blood supply to the optic nerve, we begin to see this. It's one of the causes of pallor. So a pallor is the ophthalmoscopic finding from an optic atrophy. A pallor is a sign, an optic atrophy is a diagnosis. So we do not see the paleness of the rim and call it optic atrophy unless it has been already established or we are sure that this is what we are doing. But if it is safe to say this is a pallor, then send for further tests. And then so a pallor is an inquiry, while the optic atrophy is a diagnosis. So pallor is the ophthalmoscopy finding from an optic atrophy. So pallor is what we see, while optic atrophy is what we diagnose. So what we see is called pallor, but what we diagnose is optic atrophy. So a pallor with reduced visual acuity, visual field, color vision, and RAPD is indicative of optic atrophy and not glaucoma. A pale rim is likely due to non-glaucomatous optic neuropathy. A generalized pallor could be indicative of ischemic and comprehensive problems. A pallor that is out of proportion to the degree of cupping is a non-glaucomatous cup until proven otherwise. And neuroimaging should be sent for it. Every time we see suspicious pallor, it is good we send for neuroimaging, which is MRI or OCT, whatever. So this is a disc with a diffuse pallor. So you find out that in these discs, there's a diffuse. You can hardly differentiate the disc from the cup. So this is a disc with a diffused pallor. So we will come. This is the end of today's class. Next Saturday we will continue. I want you to digest this, and then next Saturday we'll continue from where we are now to the to wherever we can stop. So I want to encourage you, please support this initiative by liking the channel, subscribing to the channel, sharing it, and then commenting on the picture. If you have any question, feel free to drop it on the comment box, or you have any observation or corrections, I'm open to learning. Please drop it on the comment box. And also I want to dedicate this video to the lecturers in Imo State University, ably led by Dr. Magnus Nsong. Shout out to them. They are doing an amazing work there, and I believe they are putting in effort to bring out the best doctors. So shout out to the lecturers, to my able mentor, Dr. Kenze, Dr. Akujobi, Dr. Jacqueline. I can't mention all the names, but they are wonderful people who guided me while I was in school. So this part one of this class dedicated to them. Long live the Imo State University Optometry Department. So thank you. I hope to see you again next Saturday by 8 p.m. on YouTube, the same place, where we'll look at the other part of the series. Have a nice day and God bless you.